Go for it.
Welcome to the Double Scrub. We're your hosts, Dr. Scott Curtis.
And Dr. Radhika Sharma, two OBGYNs who are not only partners in work, but also partners in life. That's right, we're married, passionate about women's health, and here to share it all with you.
Whether you're here to learn, laugh, or just hang out with two people who live and breathe this stuff, we're glad you're tuning in. This is the Double Scrub. Let's get started. That is your music time, isn't it?
Welcome back.
Welcome back.
Thanks for joining us again on another episode of the Double Scrub. We got the joy of actually double scrubbing together.
Yeah, we did.
This past Friday, it was a lot of fun. It's been a month. This episode's going to be released in March, but it's early March. February was a whirlwind for us. Some good stuff, but some tough stuff as well. So just do a quick summation of that.
Well, I think it started out with a little bit of learning and growth. We had a chance to go to a course together that really looked at learning a new approach to doing a hysterectomy. And so it was a really good course. And
oh yeah, and it's funny because I didn't even realize it all happened then.
Yeah.
Because so we went to this course on January the 31st, and we actually, like, as soon as we finished that course, we were like, hey, we need to do an episode right now because everything was so fresh.
Yep.
And it was so exciting. And we got home and we're like, hey, we're going to sit down for 15 minutes. And then we got a call that essentially changed the trajectory of the entire month.
Yeah, it really did. Well, someone that was obviously really important in your life and became important in my life, your grandfather. We found out he had passed away, and that obviously changed that whole weekend, and we had to quickly change plans and get up to Canada. But we got to celebrate his life, and that was wonderful.
And we all got to be together, which I think was really nice. I have a large extended family, but at the same time, we were all raised very close. And so we were able to go up there. So 3 kids that he had or has, and then 10 grandchildren and 11 great-grandchildren. And everybody was able to mobilize within under 48 hours from across parts of the country. And my grandfather had quite a legacy, and going up and being with the family and all being together and being able to celebrate his life meant a lot. We were all able to give, time for each other and with our parents. And I actually wrote down a few things that I wanted to highlight. Time is really only a limiting factor if you let it be. My grandfather's story was he was in his mid-30s when he moved his family from India to Canada. He encouraged my grandmother back in, I think it was the 50s or early 60s, to finish her medical residency as, an immigrant in the 1960s, a woman in Canada, a time where he was a trailblazer. There weren't a lot of women in medicine, let alone immigrant women. So he encouraged her to finish her residency. They had teenage children. My aunt, my uncle, and my mom integrated into Canadian society. And then when my grandmother finished residency, my grandfather actually went and did a pharmacy degree in his 40s at the University of Toronto because he realized that the skills that he had from India weren't going to transfer to Canada. And he dreamed big of his life in Canada. And he really believed in working hard, not letting time, age, and constraints being a limiting factor. And he was just a powerhouse. And he led that way in his life. He passed that on to his children, and he passed that on to his grandchildren. And really, the no excuses, enduring hard things, not coming up with a reason that something can't be done, but how to come up with a solution and how to do it and do it well.
I see that in all of your cousins and you. I mean, that was evident. And you look at the man's life and you think, like, if I could be 1/10 of that someday, and kind of reminding ourselves of like, you know, when you hear someone's struggle story, it just inspires me to say like, well, okay, I didn't have it that bad. Why can't I keep doing stuff and keep pushing forward? Like, so the path that he paved obviously has made it easier in some ways, for you guys, but the expectation was still to be great, to do great things, and I see that in all of you guys. And so that was just really his legacy, was seeing all of you together and go through that, and then, just, I mean, looking back at like even just the stages of grief for all of us. I mean, we were going through all of it at different stages, and you'd see it as different cousins would interact with each other. And I think you guys did a really good job of just giving each other patience and letting each other grieve in different ways. So it was really, really special.
And we're all at different stages in our life, but we were able to come together and support one another, which I think is something that really was what he wanted. Because at the core of everything that my grandfather, we called him Papaji, at the core of everything that he was, it was his family was truly his legacy. And he had so much pride in our successes. And, he was very hypercritical for sure, but I do think that that's part of what helped us all succeed.
Hmm.
And kind of, as much as we have high expectations of ourselves, it's allowed us to persevere through things when they don't look prototypical, right? His life wasn't prototypical, and there were lots of people who were often doubting him and expecting him to fail. And that's something that I see in our life all the time, right? You have people who are betting against you or who are doubting you, and you have to work through that and find your strength and find your character and decide what's important to you and persevere through it. So, anyways, I won't belabor it too much, but it was really a really great way to spend time as a family. And I think that it meant a lot to our parents, but it meant a lot to all of us to be there together.
Hmm.
Yeah.
Yeah,
And then we got into some endeavors.
we did.
We can talk about that a little bit.
We did. I hate to even. Funny enough, yeah, I feel like if I speak something sometimes, and this is it's probably just silly, but if I speak of it, then it disappears. It'll be like ether in the air and float away. But we had been looking at, some real estate, but actually back when you visited in November. So we thought, well, why don't we look for a bigger place? And so we did. We found a bigger place, and that has been a process with the idea of, do we start doing rentals? And that was scary. Probably because it was the unknown. Just like anything unknown is scary. But we did it. And of course, it all culminated with, renters wanting to move in, and make this official. So that left us like no time whatsoever. So I learned how to put together a lot of things.
I think what's really cool about what Scott did
Yeah.
was we took a leap of faith. We've been talking a lot about investments. We've been talking a lot about the next stages and phases of growth. And I think both of us were like, okay, when is the right time? When do you do it? What are the things that have to be aligned in order for this to succeed?
Hmm.
And I think what I learned from doing this is truly part of it is a leap of faith. You have to trust your gut instinct. I think there's a big thing of communication and
Hmm.
saying, like, what are your fears?
Right.
I feel like sometimes when you're doing like a real estate investment, probably an investment of any sort, some of it is this is what I know. There are going to be unknowns. How am I going to pivot and be okay when things don't go as we expect them to? And I think that even happened, like from putting this together.
Yeah. Yeah. I mean, well, and part of the problem I think has been because, as you said, we've been looking at this for years now.
Couple years at least, probably 2, 3.
But it was really identifying, and I'd heard this from other people in real estate, where it's like real estate's such a big word, and you think like, oh, well, I want to get into real estate. It's really like, well, what subtype of real estate are you interested in, and what subtype do you have time for? And so not every real estate's going to obviously have the same return, and not every area of real estate's going to have the same involvement. And so for us being super busy, I just realized like, okay, we have to eliminate a lot of these options. And the few options that were left were like commercial real estate or some type of long or midterm rental solution that would be that we could put in autopilot, but for this first one, it just kind of fell into place that a long-term tenant was interested, but wanted it more on a short term, but it was going to be one corporation that was going to rent the unit. And so it actually worked out really nice. So one payment, but multiple renters. So I get a little taste of all of it. That makes sense.
And I think what's really cool, I remember when we were getting into the rental idea,
Yeah.
you'll talk to different people who are like, okay, you can get in as an investor and then you can have someone manage it for you. And what I remember saying to Scott was, we actually need to see all of it first because we need to feel what it feels like
Yeah.
to like know like what's it like to furnish a room. Something that was really funny that was getting Scott like caught up was like the sheets, not the thread count, but how the sheets felt. And what about the comforters?
Mm-hmm.
And I, to be honest with you, at first I was like, man, if we just had like a management company doing this wouldn't be an issue. But then you realize when you're like heavily invested in something, not just monetarily, but with your time and with your energy and with your effort, you almost feel the fruits of your labor even more. Because I know
Yeah.
at the end of last week, I'm taking emotional support credit because I wasn't on the ground. But at the end of the week when it all came together at like kind of, the end of the time, Scott just like you could just see the pride. It was like
Mm-hmm.
finishing a project for school or something and being like, look at this. And it was really nice to see to come full circle. So I think really just if you want to get into an investment, communicating like what you want, what your potential expectations are, and then just kind of going in with an open mind, which is hard,
Yeah.
especially if you're like a type A calculated person because there's always risks associated.
Yeah. I mean, there's pros and cons to it, right? Like the pro was I realized by my my quality level, it needed to be higher. And that then made me realize like, well, I can't do slumlord renting. That would just never work for me. Like it's
Yeah.
gonna have to either be nice or I'm not doing it. And so as you're talking about the sheets, like I was trying to picture myself, well, what was it I needed when I first started going out there? And how would I want these people to feel? And yeah, there's probably a less expensive solution, but I was like, no, I want this to be nice and I want this to feel good from moment one. And will there be areas where, yeah, you can maybe tighten a little bit on, for margins or whatever, maybe. But the lack of headache, once I put it together, I'm like, this looks nice and it's all good quality stuff. No, I just felt really good. I felt really good. I felt really tired.
Yeah.
But it was one of those like you just felt like you left it all on the field. And I mean, I was staying up each night just to finish building stuff. But I did realize there is definitely a purpose for outsourcing a lot of this.
Oh
You
yeah.
know?
Like I mean,
Yeah.
but I think doing it. I really think putting it together,
Yeah. Yeah.
you're on your own. I kind of thought of something as you were talking. You mentioned something that I thought was really interesting. You said, I wanted people to feel comfortable,
Mm-hmm.
and the way to know that was to know like what I would have wanted in that space. And it almost takes me back. I think it's interesting to be a physician and now to be a landlord. I think it's part of the same things like when we see our patients,
Yeah.
we say like how would we want our mom, our sister, our daughter, your wife treated.
Right.
And it's interesting to make that connection because now as a landlord, yeah, the easy way would be like just put in stuff that isn't necessarily ideal.
Yeah.
But I think when you treat people in kindness and you treat people like in a home situation, even if they're paying you for it,
Yeah.
if you're treating them that way, I think it'll come back in kind. Mm.
So I think, you don't have to cater to the lowest denominator. You can set a price and it might be premium. As long as you're delivering premium, people are going to be okay with that.
Yeah, treat people with kindness, respect, and how you would want to be treated.
Yeah.
Really, I mean, it's the golden rule, I
And
guess.
it might not work for everyone, meaning like, yeah, there will be some tenants that will not stay with us. That's okay.
Yeah.
But I can keep it to a certain level of quality and we'll find the right tenants and that's fine. Scaling is going to be the next thing that'll be interesting. So obviously me staying up, at all hours of the night to build and put together this first one. Yeah, I cut my teeth on it. We got to skin our knees and see what it's like. Um, but it's not the way we can scale. And I realized like the clock was running out for me. I think I got to Saturday and I was flying out Sunday. And finally I broke down and I was like, wait a minute. In my little list of people that I was putting together to like help manage this was a handyman. And literally I had left caulking and I was like, I don't know how to caulk. I was gonna try to figure this out. Like, but I just ran out of time and frankly energy. Like I'd been up all night and like there were deliveries and other stuff. And so it was like, I've got to outsource this. And it felt so hard. But as soon as I let it go and I message and he's like, I can be there in 20 minutes and we can look at it together. Okay, that's amazing. Comes over, he looks at it. Yeah, I can have it done on Tuesday. I'll bring my own stuff if you don't mind the stuff I had picked out. He didn't like it.
So I'm not surprised.
Yeah, so clearly like I didn't even know what stuff to pick, right? And so he came, he did a great, I mean, I was back home by that point. He texted me pictures of it that it was all done. It looked beautiful.
Yeah.
Would have been way better than what I would have done.
Sure.
Probably way faster.
Yeah.
So it just showed that, okay, it validated the idea of like, yeah, it's okay to let go of this stuff and outsource it.
Yeah.
That doesn't make you any less handy. It just, that's not my skill set.
And that's okay. Yeah, it's totally fine. I think it was exciting start to the endeavor and you're learning every step of the way. So.
But we got to focus on our skill set together. And that was the big thing this week was and I'll let you speak on it, but it was really nice to be in that case with you. And there was a moment literally in my mind where I was thinking of the handyman caulking stuff. I'm like, well, this is my type of caulking. Like this is what this is my skill set.
So yeah, that's kind of one of the major things we were going to talk about today. I've had several questions recently from whether it be people on Instagram or I've noticed like from friends and things. People are like, can we talk a little bit about hysterectomies? And really the one we want to talk about today is the vaginal assisted nodes hysterectomy. And the reason we want to bring it up is that's the course that we were doing back at the end of January. But also, I think we wanted to kind of discuss why we liked it and why we think it's a really cool approach. It's not exactly completely novel or new.
Yeah. Yeah. No, it's taking something old and putting a little new spin on it. And
which is great because I like how medicine's advancing. Yeah. The cool thing with this hysterectomy, the rep who came to the case said it best. He's like, actually, this may not be the most ideal for the doctor, but it is the most ideal for the patient.
Well, it can be. I mean, I'd put a big caveat on this.
That's
like,
fair.
If you're listening to this and you're working with a doc and they're recommending a hysterectomy in a certain way, trust them on that because each of us are going to have our own skill set and we're going to be better at doing a hysterectomy one way or the other. And in your particular situation, it may be better in a certain way than the other. So this was specifically looking at, hey, if you were planning on doing a minimally invasive hysterectomy, but you wanted to avoid even the little incisions on your abdomen, we've got this novel approach of everything through the vagina. Whereas before, it was really your dexterity. You had to be able to manipulate your hands with small clamps, and everyone's hand size it just didn't work for. And over a long time, like it would be really hard on your hands, and just your posture and everything about it. It was just a really tough case to do. So what they did is they figured out a way of like, well, look, we can put actually a laparoscope in, which is a small camera, and small laparoscopic tools, which are, think about it like little pinchers on the end of long straws that can go in and do the job for you all through the vagina. And you did your first.
I did my first. So awesome. I think we should give a little bit of background. I always think like cold hard facts are kind of fun, especially if you're listening like not from a total medical perspective. But
nerd out.
I'm gonna nerd out. I have some facts here. So 1809 was the first recorded hysterectomy by Dr. Ephraim McDowell in Kentucky.
How did that one go?
I know. He successfully removed a large ovarian tumor from a patient without anesthesia or antiseptics. So think about that. Like there was no anesthesia to put the person to sleep. Antiseptics meaning he didn't give antibiotics. We routinely will give you antibiotics prior to hysterectomy. So the risks associated with early hysterectomies were like blood loss, lack of surgical precision, and this was again 1809.
I just can't imagine. They didn't even have cars. What were we doing?
The horse and buggies. I mean, but here's the thing. If so, it sounds like he was obviously working to try to save this person's life because they had a large ovarian tumor. So, that's nice. Even without a car. And surgical techniques advanced in 19th and early 20th centuries. We got some antibiotics. Hallelujah. We got some anesthesia, and then we improved our suturing techniques. So then in the 20th century, there were abdominal and vaginal hysterectomies, which when we trained, abdominal hysterectomies were not the mainstay, meaning like often, going through a cesarean section scar. But, they were still very useful for certain cases. And then in the late 20th century, that's when
The way you say 20th century, it just makes it sound like it's so long ago.
well, okay.
Are we talking like the 80s, the 90s?
No, now they're saying the late 20th century. So the robots were in the early 2000s, late 90s, early 2000s when we first got the laparoscopic and robotic assisted hysterectomies. And the nice thing with those are those like minimally invasive techniques that Scott's saying. So the laparoscopic and robotic assisted, and what the reason that they were better or considered to be better is that recovery time for the patients were less.
Incisions. Yep.
Blood loss was less, complications were less, and people were going home much more quickly. I learned, and I remember when my mom had her hysterectomy, she had a big abdominal hysterectomy. It's funny, I remember this. I was like probably like 10 or something. She was in the hospital for 6 days.
They used to just do that. Like they'd keep everyone in the hospital.
They were just trying to give everyone like DVTs or something.
I don't know what it was. Or infections were that bad back then that you'd watch and see if something started brewing. Yeah. I don't know. I mean, there had to be some reasoning behind why we'd stay in the hospital so long.
So what's interesting now is even the American College of OBGYN, there's a lot of data that comes out regularly debating which one is quote unquote better. And I will say nothing we say in this podcast is a medical recommendation. If you have a question, reach out to your OBGYN or your physician and ask them. But the data is still bouncing between what's better, a laparoscopic or a vaginal hysterectomy. I think Scott said it best. It really depends on the comfort of your surgeon, why you're having the surgery. And, those are two of the most important things, right? And then the discussion you have with your surgeon.
Right.
And so, yeah, the vaginal hysterectomy generally has been shown to have a faster recovery. But to be honest, the robotic assisted hysterectomy or the laparoscopic hysterectomies are definitely catching up. The big difference is when you do things through the vagina, there's a very low risk of any injury. There's no incisions on your abdomen.
Mm-hmm.
And then with the robotic hysterectomy, you're still using little incisions with the camera to get in.
Right.
But both are really, really good. And they both are have their place, I would say.
Yeah, and I mean, we're getting to a point now where it's getting to finesse, like we're at a 95% solution. So we're just playing with the last 5% now. Can we reduce pain just a little bit more by having a few less incisions? Maybe. That's what we're trying to see with this V-nodes procedure.
Yeah.
But do people do well with the other ones? Of course, they go home the same day. I mean, all of our surgeries are going home the same day now, which is even unheard of from when we were training. It was like, of course you keep them overnight and watch them.
Mm-hmm.
But now, and this is a whole different topic, but like I've heard that like insurance doesn't even, unless you have a reason, they won't even let you keep a patient overnight. Even if you're like, I just kind of want to watch them. Like, well, good luck. They're going to get a huge bill. So you better have a reason or they better be ready to go home.
Mm-hmm. And I think that our anesthesia techniques have gotten so much better, whether the hysterectomy or the surgery even is done via a robotic or a laparoscopic approach. And just to kind of explain again, you have small incisions that get placed on your belly for a laparoscopic or robotic approach, or whether it's done vaginally where the cervix and the uterus and potentially fallopian tubes and ovaries come all out of the vagina. The anesthesia is doing such a great job of recovery that these patients are our patients are up and moving within an hour and a half.
Yeah.
And
True.
then they're eating, they're drinking, and overall, the faster recovery time in the recovery room,
Hmm.
we're finding that, you talk to the patients a day, 2, 3 days later, and most of them are like, how long do I have to be out for? I feel great,
Right.
which is really, 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 really nice.
Yeah, and I'd have to go back and look on the history of it, but I want to give credit to probably the thoracic surgeons. They do the open heart and have the patient up walking like a couple hours later. So it's like, well, hold on, like if they can get their patients up, like what are we doing? Like we should get our patients up faster.
Yeah,
And
I mean, even when we were in residency, do you remember? Like, we would have patients have C-sections, and they'd be like, okay, the Foley catheter has to stay in for 12 hours.
oh yeah,
So now it's really nice. They call it ERAS now, Advanced Recovery After Surgery. And essentially, there's all these principles for whether it be gynecology, orthopedics, cardiac surgery. It's these principles of having people up, moving,
yeah,
eating, drinking after your surgery, whether it be robotic, vaginal, even
yeah,
abdominal hysterectomies. I mean, we have our C-sections up within 4 to 6 hours.
right. And that really looked into the idea of pre-medicating before the surgery to really lower those pain receptors. So I think we're seeing advances in all areas, from pharmacology to anesthesia, as you said, to, even now the finesse of how we're doing those procedures. So the robot seemed like that was the solution because it was just so much nicer ergonomically. But the robot's a big cost. It's
Mm-hmm.
it's not available everywhere. So
Not
especially
everyone's comfortable with it, meaning not the surgeon, but you also need a very good support staff to feel comfortable with
right.
troubleshooting when the robot isn't, working appropriately. And in a lot of places where if you're not close to a big city,
Yeah.
you don't have as many people. It's just reality.
Well, and its cost point is just it's prohibitive for the small hospitals, which it would be so nice. I mean, I was looking down the road to think like, oh, this is gonna be awesome. Like, put robots in every hospital. You may have support staff there, and you could literally have a really good surgeon tele in and do the surgery remotely. And maybe that's still where they'll go at some point, but we're ways off from that right now.
Yeah.
And so the better solution, or at least the solution for now, is well, do we have a way to do minimally invasive surgery that's still good on the ergonomics of the surgeon, but has a low cost point that we can do it at any hospital? And that's kind of where
I think V-Notes came in.
I got excited by that. Yeah.
And I kind of did a quick look at like what the recommendation to patients is, why, recommending the suitability of like a vaginal hysterectomy versus a robotic hysterectomy.
Hmm.
And still a lot of what we're seeing in like the literature and on websites is that, the vaginal hysterectomy is still very much ideal for non-cancerous conditions and where the uterus is not too large. Whereas a robotic hysterectomy, where you have the incisions on your abdomen and the surgeon is sitting at the robotic console, is ideal for like more complex cases, someone with like endometriosis or a larger uterus. But let's dive into the V-Notes procedure and talk about like what we like about it maybe.
You really
and
want to nerd out on this?
Well, do you want to or not?
Talk to me. Yeah.
So, I felt like we were lucky enough to get really good training in vaginal hysterectomies.
Hmm.
So the nice thing with this V-Note surgery is, again, we're going back to our basic principles of vaginal surgery. And then I think the coolest thing about it is we can still do the vaginal approach,
Hmm.
but with a laparoscopic camera through the vagina. So I remember when I was talking to a couple of my patients about this, they were like, wait a second. You're using a scope vaginally
Hmm.
to do the rest of the surgery. And so I think people were even having a hard time appreciating how it was going to work
Mm.
because of like the videos, or when you Google online, you don't see vaginal endoscopic surgery. You see robotic surgery or laparoscopic assisted
Yeah.
surgery. So then actually changing the discussion with your patients, because now they're like, wait, if this is a new approach, what's our first human thing? Well, I don't
Yeah.
want to do something that's new.
Right.
right?
Well, I don't want to be the guinea pig.
I don't want to be the guinea pig.
But the truth was, we were already doing this surgery just with a step before it, which was stab you 3 times in the abdomen to put a camera in from above
Okay,
and put tools up above.
can we say that in a less?
What? Well, it's a stab wound.
Okay,
I mean, that's the truth, and that's why like getting rid of those is so important because then you don't have that pain.
yeah.
I mean, that's literally how I can. I don't know how you counsel your patients, but I'm like, you're gonna have 3 stab wounds on your abdomen.
I just
They're
tell
gonna be
them that
sore.
there's going to be like 3 to 4, depending on the type of like the laparoscopic surgery you're doing, that are like about 8 millimeters to 10 millimeters. But yes, and that you're not wrong. It just sounds
Sounds brutal.
sounds brutal. But I guess you know what the truth is. It's better to be
Honest.
open and honest about it. But what we are finding is that the cool thing with this procedure is you could have the visibility that you couldn't have previously when you were doing a vaginal surgery
Mhm.
because you would do a lot of it through feel, but now we're able to use the scope and see things. And even with my first patient, she had 2 previous cesarean sections, which can lead to scarring on the uterus. And my big concern was, okay, robotically, when I'm looking into the abdomen, I can see everything. So, that's going to help me be able to visualize what to do. But to be honest, this, as we're trained surgeons, so we understand the anatomy of it. This was no different. It's
Mhm.
just taking it from more of a microscopic lens, which is really cool. So I really appreciated the surgery. The patient did really well. She went home, within a few hours after the surgery, walked, ate, drank, walked to her car.
I thought I did really well.
I thought you did great because it does actually. It's interesting because this one, at least in the beginning, and most vaginal surgeries, I prefer to double scrub. The name
Yeah.
of this podcast is because it's nice to have someone who can troubleshoot if you run into a situation, because it's really nice to have a secondary perspective, I think.
I was joking more on the standpoint of I didn't get a chance to operate with you for a long time. And one of the biggest things that used to drive Radhika
Oh,
nuts
this was funny.
was I will like either out of nervousness or just out of like I as I'm
Well, I think it's just what you do.
as I'm doing the case, I'm literally talking to myself in my head. I'm almost like my own self coach, and I'm probably hearing my attendings or other people that have trained me in their voice style saying it to me in my head of every step I'm doing. Well, unfortunately, for anyone I'm operating with, that comes out verbally. So every step as we're going along, okay, now I would do this, now I would take this, now I would go here. And at one point, Radhika's like, "You're talking too much. You need to be quiet." And so I had to bite my tongue, and I was like, "Okay, be really quiet. Just focus on keeping the camera right where she needs to be." So that's all I meant. I was like, at that point, I felt like I shut up pretty good right till the end of the case.
I thought it was funny though because, and I remember that from like we've been operating together for years, and it's true. Like it's literally just natural for him to be like, "Okay, we're gonna do this next. Okay, oh, we need to restore anatomy here," and it's like it's just his brain thoughts coming out verbally.
Yeah.
But at that point, I was like, "Okay, I really need to focus. So you need to
Like
stop
I
talking."
like I was about to get stabbed.
And so, but then he got really quiet, and I was like, hello, where did you go? So it's finding that happy medium, but it is quite fun to operate
Yeah, it
together.
was.
And the rep who was in the room, he was laughing the whole time. Like I'd say like Bob was laughing like 80% of the time, especially when we got to the end because things were going really
I
well.
don't know if it was an awkward laugh, like, "Oh, awesome." Like, it's fine.
Yeah. Sometimes I feel like it would be fun if we just put like um like a tape recorder, old school style, like in the back, so you could just hear the banter. Because sometimes it gets really good, especially
Yeah.
if things are like wrapping up and we're getting close to the end. Like there's some funny stories that come out usually.
Yeah. But no, but I thought you the case was not straightforward. You troubleshot each little step very well. I thought it was a really good case. And I think I'm glad the patient's doing well, but just, yeah, it was a lot of fun to do that case with you. And again, kind of like the real estate of like, oh man, little problems keep popping up and you just got to keep knocking them down. Same thing was happening in that surgery. Like, okay, little problems pop up, just knock them down, knock them down, knock them down.
Which is,
Well,
it's
yeah,
never, I would never say a surgery is ever easy.
no.
I would say it's complex or less
What was
complex.
it Hopkins used to say? There's no such thing as a simple surgery, just a simple
Simple
surgeon.
surgeon. Oh, yeah. Man. Hopkins was our program director, and he had some good advice, and, really respect him. So, anyways, yeah, it went really, really well. I look forward to our next surgeries
Hmm.
together for those. And yeah, I think the main thing is if you are planning on having a hysterectomy or looking into one or have questions about it, talk to your surgeon. I always like the patient who we did the surgery on last week. I told her straight up, I'm like, look, I usually would have done this robotically.
Hmm.
We have a newer idea. I think the most important thing in a patient physician relationship is being open and honest. I mean, we tell our patients go in with the expectations of I'm going to ask all of my questions as a patient. I want all of these answers and I'm going to make an informed decision for what's best for me.
Well, so what if a patient doesn't have an idea of what questions to ask?
Yeah, that's great. That's a great point.
You know what I mean? Because like even going back to the real estate thing, like it wasn't until like I stumbled through some stuff like I didn't even know to ask that.
Mhm.
So someone's coming to you. I mean, one, why are you even going to offer my hysterectomy?
It's funny because I just did a reel on that because I had people saying, like, when is it offered?
Yeah.
I would say some people, if they've been having heavy menstrual bleeding or heavy periods, or if they've been having abnormal periods for the last several years and they're done having babies, figuring out why, getting the etiology, making sure that it's not like a thyroid disorder or something else. But then if
So they're coming to you for heavy bleeding.
heavy bleeding.
Yeah.
So I'm going to say, look, like, let's make sure it's not, an endocrine issue. And then also, like, let's make sure there's no structural issues inside your uterus.
Yeah.
So, like, if you had fibroids, and you're done having children,
Hmm.
a hysterectomy may be a very good option for you.
Right.
Or if you're having so much bleeding, like this patient where she was a runner and she was getting anemic and needing iron transfusions.
Oh
She's
wow.
done having babies.
Yeah.
It's a good option for her. Her uterus wasn't overly large.
Yep.
So giving her a hysterectomy, a removal of that uterus to remove that bleeding and remove that risk of anemia is a good option for her. Whereas someone who's maybe like, look, I'm not ready to remove my uterus, which there are people who feel like that, then there are other options for them other than a hysterectomy. I think really I like to lay it out in like, what is your ultimate goal?
Hmm.
And some people are going to say, I just want to know why. I don't even want any treatment. I just want to know why this is
Right.
happening. That happens, right?
Oh yeah.
And then you have people who are like, I want the step that I can take that is the least invasive, meaning I don't want to lose an organ. Maybe I want medical management. Maybe I want a simple procedure that might be a band aid. But if someone comes in and saying like, I'm done, which I call definitive management, meaning, I'm done. I don't want to deal with medication anymore.
Hmm.
I don't want an intrauterine device. I don't want a Band-Aid. I just want I just want a hysterectomy. We talk about the risks, the benefits, the alternatives, how it might have lifestyle change, what to expect postoperatively.
Hmm.
We go through all of that. It's a very in-depth conversation.
Yeah. And I'm just thinking through what you've said, and
Yeah,
I
and please
pretty
add
much
on.
no, yeah, and I pretty much do the same. I mean, the TLDR is that someone comes in heavy bleeding, and we say, first things first. We need to
Wait,
do
what's a TLDR?
too long didn't read. For all of us that don't want to read too much, we just jump to the end.
Okay.
So the end for me is, well, we need to do a small workup for your bleeding, CBC, how much blood have you really lost?
Yeah.
TSH, looking at your thyroid.
Mhm.
We need an ultrasound to see if there's anything in your uterus, as you were saying.
Mhm.
Endometrial biopsy,
Yep.
little pipelle that goes up inside the uterus, collects tissue, send to the pathologist to make sure there's no cancer.
Yeah.
You do those three things. Then you look at your different options, the non-surgical options, as you were saying, the hormones,
And not always hormones. There are other options other than hormones.
the ablation,
Mhm.
or hysterectomy.
Yeah. I think asking the questions, being like, okay, so I'm having this bleeding. What are my options?
Hmm.
And maybe one thing that's important is to advocate for yourself with what you want. Because again, as I said,
Yeah.
some people do know that they want definitive management, and they come in the office and they say, "Yeah, I know what I want."
Right.
and then having that conversation and just being really comfortable and honest and open.
Yeah.
I always suggest writing your questions down in your phone or on a
Yeah.
piece of paper,
100%.
because 90+% of the time, people would be like, I had another question. Or if you have like a friend or a family member or a support person that you feel that can come in with you, I have people writing notes all the time.
Totally.
And I'm okay with, I also do the whole like, because, sometimes I can pick up that people want to make a decision once they go home. I'll say, okay, let me print you some information.
Right.
Asking for information from your doctor's office on what to expect before the surgery, during the surgery, and after the surgery is a very, very good thing to do. And then coming back and
Coming
asking
back.
questions.
Or even getting a second opinion.
Second opinions, totally.
I try to tell patients that all the time, that like, I would never be offended. And if I were to get offended that you would get a second opinion, that's not your fault. That's my fault.
That's a pride issue
that's some internal thing that doctor needs to get over.
Mhm.
Because we're all gonna present the situation, or we're gonna come to the table differently and deal with the situation and present our ideas differently. And for some people, it's gonna stick. For other people, it's gonna be like, ooh, that doesn't sound good. I mean, there's some doctors that lean more towards surgery,
Mhm.
and then there's some doctors that lean more towards avoiding surgery. And whether that's right or wrong for you, that's really your choice. It's just their job should just be to offer you the information, give you options. You get to decide where to go from there.
I think that's important. Really, a common term that's used now is like shared decision making.
Yeah.
And even more, so shared to me seems like an equal opportunity between the doctor and the patient. But I would almost argue that we're here to present the information, support you in your decision making, and you ultimately make what decision is best for you in your life at that time.
Yeah. Now I'm going to have some boundaries, just like every physician will, of like, look, you can't come in when you're 16 and say, I want a hysterectomy. It's like, well, that's neat, but I don't do that. So,
And I would say like not a can't, but really, and
well, I wouldn't. I
especially
mean,
okay, yeah.
16
But
year
I'm
old.
saying
No way.
I'm just saying, like, sometimes people come in with preconceived notions, whether it be from stories that they've had from friends or family or Dr. Google or social
Yeah.
media. And I think that is really an opportunity for us as physicians to educate people
Right.
on their concerns. Because most of the time, if you have someone, I agree with Scott with boundaries, but if you have someone who's coming in with a very strong opinion that seems kind of like, okay, there's usually something under that.
True. True.
Yeah. So,
Yeah. And I agree with you. I mean, like if they've got every reason to, like, let's go down the road of like they want surgery and 3 docs have shut them down, making sure that I take the time to ask, well, why did they shut you down?
mhm,
Oh, maybe they don't operate a lot, so they don't feel comfortable with it. Maybe they've got their own opinions on, how many children you should have, which is frankly none of their business.
right.
That those type of interactions aren't fair. And so I agree, like that type of patient, no, I've got to make sure I'm hearing them. What is it they really want? They've clearly spent enough time thinking about it and giving them the autonomy to make that decision. Totally.
Uh,
But just making sure you've got the doc that, like, I don't know, you can relate to. Because I mean, we dealt with that even just recently with my mom, where
oh, yeah.
she needed a procedure done, and she called and she's like, I just don't feel like the doctor did a lot. And I'm like, okay, well, tell me what happened. And she's talking about it, and like, this doctor didn't even do an exam on the follow up. But at the same time, like, you have a bad feeling about this doctor. You
And I would
are
I
open enough
would
to
argue
talk to
it's
me about
not
it.
it wasn't a bad feeling. She didn't feel comfortable. Those are the words she used. I
True.
didn't feel like she wasn't here. She was hearing me. And so I think Scott made a very good point. Second opinion, number one. And number two, it's like having the right fit is so important,
Oh yeah.
right? We think about that even with like the right fit with like our teachers or whatever. But if you are speaking with a doctor and you're not feeling heard, or you don't feel like you're clicking with them, and I've had people go to a different doctor in the same group. That's okay.
Mm-hmm.
As Scott said, none of us should take it personally.
Right.
You have to pick the right relationship and someone who makes you feel comfortable and makes you feel heard and makes you feel validated, your
Yeah.
concerns valid. And not every doctor is going to give you that feeling.
Right.
Some people want that person who's more curt, who's more short, who, just gives the facts. And then some people need someone who's going to sit there and kind of hold their hand a little bit
Yeah.
more. And, as you said, the way medicine is right now, we need to, because there's a shortage of doctors too, we need to see as many patients as we can, but finding as we can for access, but finding that connection and finding that, because then when your mom went to go see, we were able to find someone through our network who she had to drive to go see them. But when she went to her appointment, you could just tell, like, Scott's mom felt way more at ease.
Mm-hmm.
She answered the questions, and she actually had me on FaceTime just because she wanted to make sure again, calling in a support person.
Mm-hmm.
So I could help her kind of keep the knowledge because there's anxiety going in,
Oh, yeah.
having an exam with a new doctor. And I thought the physician did a phenomenal job of just breaking down her options,
Yeah.
talking to her about age appropriate and, options that would work best for her in a simple way with pictures, which I think pictures and models are like amazing, especially as a gynecologist,
I know.
and making it
I
less
know. They're really
scary.
good.
But
Yeah.
making it less scary, right? Because before coming out, maybe the way the doctor approached it, it wasn't that she was, again, a bad doctor or lied, but I think her relationship with your mom needed someone who was going to hold her hand a little bit more.
Mm-hmm.
And the other doctor was a little short and curt. And so, again, relationships are different.
And
That's okay.
well, right, and that was, as you were saying, like it's no knock on the other doc, because I don't know what her day was like either, and that's the one problem. Like when we get into the room, we're trying to put 100% on whoever's there in front of us, but unfortunately, you may be the 20th patient of the day. That doc may have been up all night dealing with a delivery or something else, and so it's really hard for us to tune in. You know, it doesn't give us an excuse though, but it's really hard for some of them to tune in at different moments. And I'm guilty of it as well, where it's like, man, that appointment was just not how I wanted to go. Sometimes if I can catch it before I leave, I'll even try to do a two week follow up. Just like, hey, see me again in 2 weeks. Where it's just like, man, that didn't go the way I wanted. I think we have a little bit more we can talk about. And if they're willing to, then cool. We'll see each other again.
I feel like we could do a entire episode on physician empathy for physicians and empathy for patients. I mean, just realizing that we are all very much doing the best we can. And
Yeah.
going back to the idea of, like, we don't know what's going on with someone's day. Sometimes you have patients that come in and they're definitely curt and they may seem upset, but it's not coming from a point of, like, being upset at the physician or being upset at the nursing staff or being upset at the hospital. It's just, they're having a bad day. And so meeting them with empathy and conversely meeting your physician with empathy too. But yeah, I mean, I think that's good. Anything else you want to add? We're doing good here. But it was a great conversation otherwise.
What do I want to talk about next? I want to talk about your love of these miniature cows.
Okay, we're going to finish on the miniature cows. Is that fair?
Yeah.
Okay, cool. So these miniature cows, to me, they look like almost like the size of a.
Well, what type are they? They're Highland
The
cows.
Highland cows. Oh,
And they're small.
there's something that's
And they're super cute.
beautiful about these Highland cows, and they look like their hair is like so soft and flapping in the wind. My problem is, I think I would want to put them in the house because it'd be like a cuddly little bear.
Which I never realized people were doing that.
They are. And then the other thing I wonder too.
I thought you were just putting them outside, which I'm like, yeah, let's do it. It's the size of a dog. Why not?
I think so. We're like a large dog. Number one. Number
You
two.
Google that.
I don't know how much they weigh. And then, like,
I'll tell you.
do they eat like regular cows? Do you get them cow? Like, I don't know.
What do you mean? No, they eat miniature corn and miniature
I don't know.
grass.
But anyways.
Oh, damn. Okay, this is not a dog.
Half a ton.
This is a miniature Highland cow, typically weighs between 500 and 700 pounds.
Yeah, what did I just say? Half a ton.
You're going to bring that in the house?
No, I guess not. And then.
There's nothing miniature about these. 500 pounds?
I mean, I don't know. Anyways.
The pictures you were showing me, it must have been like a baby.
I was about to say, like, this episode was almost not going to
This
happen.
episode was brought to you by two parents who had a wonderful school night last night with some great parents, by the way. We didn't even talk about that, but our kids are very fortunate to go to a very fun school. And we had
I think
fun parents that are
it's like
involved.
this. If you listened back to last episode about the village comment, we are very, very grateful, and we feel very lucky to be surrounded by a community of very invested families at this school. And we went to this fundraiser where people just opened their hearts.
And then tried to poison us.
They didn't try to poison us.
You tried to poison
I
me.
definitely did.
Yeah.
Thank you, Brooke, for
But we
the
survived.
introduction of the tequila gimlet. And we got through a hour-long podcast. And now I'm gonna go take care of the kids.
Okay, how do you end this again? What's the first phrase you like to say?
Let's break scrub.
All right. Thanks, everyone.
Thanks for joining us for this week's episode of Double Scrub. We hope you learned something, laughed a little, and feel inspired to take on your week. Don't forget to subscribe, leave a review, and follow us on social media. We'd love to hear your questions, comments, or ideas for future episodes. Until next time, keep it balanced, keep it real, and remember, we're all just scrubbing through life together.